Cancers of the colon, rectum and anus Q&A, Part 4. Welcome to today's podcast, where we discuss cancers of the colon, rectum and anus. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of cancers of the colon, rectum and anus. Pause the podcast after each question to attempt answer. Let's begin. Anal cancer anatomy and pathology question. What is the definition of the anal canal? Answer. The anal canal is the most distal part of the gastrointestinal tract, measuring about 4 to 5 centimeters long, and extends from the anorectal ring to the anal verge. Question. What is the histological composition of the anal canal? Answer. The anal canal contains rectal columnar epithelium proximally and squamous epithelium distally, with an area of overlap known as the anal transition zone. Question. What is the most common type of cancer found in the anal canal? Answer. Anal squamous cell carcinoma is the most frequent cancer in the anal canal, while other types of malignancies are extremely rare. Epidemiology question. How prevalent is anal carcinoma? Answer. Anal carcinoma is rare, accounting for 1 to 2% of all large bowel cancers, and affects approximately 10,000 people annually in the United States. Question. What are the demographic characteristics of anal carcinoma? Answer. Anal carcinoma is more common in females, with a 2-to-1 ratio, and the highest incidence is observed in white females and black males. Question. What are the recent trends in the incidence and mortality of anal carcinoma? Answer. The incidence and mortality rates of anal carcinoma have increased over recent decades, with the average age at diagnosis being 61 years. Risk factors question. What is the primary risk factor for anal cancer? Answer. Human papillomavirus infection, especially genotypes 16 and 18, is the main risk factor for anal cancer. Question. How is human papillomavirus typically transmitted, and how does it affect anal cancer risk? Answer. Human papillomavirus, the primary cause of anal cancer, is usually transmitted sexually, with increased risk associated with anorreceptive intercourse. Question. What are other risk factors for anal cancer? Answer. Additional risk factors for anal cancer include human immunodeficiency virus infection, age, cervical cancer, tobacco use, and immunosuppression. Clinical presentation question. What are the common symptoms of anal cancer? Answer. Common symptoms include bleeding, mass or fullness, itching, pain, or anal discharge. Question. Why can anal cancer symptoms be misdiagnosed? Answer. Symptoms of anal cancer can be mistaken for benign conditions such as hemorrhoids. Question. What symptoms might indicate advanced stage anal cancer? Answer. Advanced stage symptoms include bowel obstruction, incontinence, rectovaginal fistula, or inguinal adenopathy. Clinical evaluation and staging question. What diagnostic procedures are used for evaluating and staging anal cancer? Answer. Clinical examination, endoscopy, and imaging are used for evaluation and staging of anal cancer. Question. What does clinical examination assess in anal cancer? Answer. Clinical examination assesses the characteristics of the primary tumor, involvement of surrounding structures, and the presence of inguinal lymphadenopathy. Question. How are endoscopy and colonoscopy used in anal cancer evaluation? Answer. Anoscopy or flexible proctosigmoidoscopy is used to determine tumor location and allows for biopsy, while colonoscopy is performed to rule out synchronous colorectal cancer. Question. What additional screening is recommended in anal cancer evaluation? Answer. Cervical cancer screening is recommended for females, and human immunodeficiency virus testing is recommended for both genders. Question. What imaging is recommended for anal cancer staging? Answer. Cross-sectional imaging of the chest, abdomen, and pelvis is recommended to assess local and distant disease, and pelvic magnetic resonance imaging is used for primary tumor evaluation. Question. When is lymph node biopsy indicated in anal cancer? Answer. Biopsy is indicated for clinically suspicious inguinal nodes, especially if they are not fluorodeoxyglucosavid on positron emission tomography scan. Treatment. Anal margin squamous cell carcinoma question. What is the definition of the anal margin? Answer. The anal margin is the area that extends 5 centimeters radially from the anal verge onto the perianal skin. Question. How is squamous cell carcinoma of the anal margin managed? Answer. Squamous cell carcinoma of the anal margin is managed in a manner similar to squamous cell carcinoma skin tumors in other parts of the body. with management depending on tumor size, location, and histologic features. Question: when is wide local excision appropriate for anal margin squamous cell carcinoma? Answer: wide local excision is suitable for tumors with adequate margins, without involvement of the anal canal or musculature, and without high-risk features. Anal canal squamous cell carcinoma. Question: what is a possible treatment for early anal canal squamous cell carcinoma? Answer: local excision. Question: what is the recommended treatment for early lesions of anal canal squamous cell carcinoma without high-risk features? Answer: local excision is considered an option for early lesions without high-risk features. Question: what surgical considerations are important for early, superficial lesions of anal canal squamous cell carcinoma? Answer: early, superficial lesions may be resected with 1 cm margins if they do not involve the sphincter complex. Question: what is the post-surgical management for anal canal squamous cell carcinoma? Answer: surveillance may be sufficient if surgical margins are negative and there are no high-risk features or nodal disease. Question: what are the main treatments for anal canal squamous cell carcinoma besides surgery? Answer: radiation and chemotherapy. Question: what is the standard treatment for anal canal squamous cell carcinoma? Answer: the standard treatment is concurrent pelvic external beam radiation and fluorouracil with Mitomycin C. Question: what are the outcomes of standard treatment for anal canal squamous cell carcinoma? Answer: there is an 80% complete response rate and a 72% colostomy-free rate. Question: what is the goal of treatment for anal canal squamous cell carcinoma? Answer: the goal is definitive treatment for anal squamous cell carcinoma in the majority of cases. Question: what are the standard treatment approaches for anal canal squamous cell carcinoma? Answer: standard treatment approaches include fluorouracil, Mitomycin C, and radiation therapy. Question: what alternative treatment can be used in place of Mitomycin C? Answer: cisplatin can replace Mitomycin C without negatively impacting oncologic outcomes. Question: what should the radiation field encompass during treatment? Answer: the radiation field should include clinically or histologically positive lymph nodes. Question: when should treatment response be evaluated after therapy completion? Answer: initial evaluation should occur at 12 weeks after therapy completion, using anoscopy or proctoscopy and digital rectal examination. Question: what should be done if there is a good but incomplete response to treatment? Answer: reassessment should be performed in an additional 6 weeks. Question: what is the surveillance protocol after treatment if no residual disease is found? Answer: if no residual disease is detected, patients can enter surveillance protocols, and if there is no progression after 6 months of surveillance without surgery, surveillance may continue. Question: what is the complete response rate at 11 and 26 weeks after treatment? Answer: the complete response rate is 64% at 11 weeks and increases to 85% at 26 weeks. Question: how many patients with a good but not complete response at 11 weeks achieve a complete response by 26 weeks? Answer: 72% of patients with a good but not complete response at 11 weeks achieve a complete response by 26 weeks. Question: what is the 5-year overall survival rate for patients who fail to achieve a complete response at 26 weeks compared to those who do? Answer: the 5-year overall survival rate is significantly lower at 48% for patients who fail to achieve a complete response at 26 weeks, compared to 87% for those who do. Post-treatment evaluation and surveillance. Question: what is the recommended follow-up after complete remission following chemoradiotherapy? Answer: digital rectal examination and inguinal node palpation every 3 to 6 months for 5 years, anoscopy every 6 to 12 months for 3 years, and annual computed tomography scan of the chest, abdomen, and pelvis or pelvic magnetic resonance imaging are recommended. Question: what is the follow-up protocol for stage 2 or 3 anal cancer after chemoradiotherapy? Answer: annual computed tomography scan of the chest, abdomen, and pelvis or pelvic magnetic resonance imaging for 3 years is recommended. Question: what is the recommended treatment for local recurrence of anal cancer without metastatic disease? Answer: abdominoperineal resection is recommended for local recurrence without metastatic disease. Salvage surgery. Question: what surgical treatment is recommended for patients with persistent disease after chemoradiotherapy or local recurrence? Answer: surgical treatment with abdominoperineal resection is recommended. Question: what preoperative evaluation is necessary before salvage surgery? Answer: Cross-sectional imaging with pelvic computed tomography or magnetic resonance imaging is necessary to assess the local extent of disease and determine whether en-bloc resection of other organs is needed. Question: what surgical principles should be applied during abdominoperineal resection for salvage surgery? Answer: general surgical oncology principles for abdominoperineal resection using total mesorectal excision, similar to those used for rectal cancer, should be applied. Question: when is formal groin dissection recommended? Answer: formal groin dissection is recommended for pathologically proven or clinically suspected positive inguinal lymph nodes. Question: what is an important prognostic factor after surgical resection? Answer: negative margins after surgical resection are crucial for a positive prognosis, with R0 resections potentially resulting in a 5-year overall survival rate of up to 75%. Question: what wound management techniques are commonly used following extensive surgery and radiation therapy? Answer: rotational tissue flaps, such as vertical rectus abdominis myocutaneous, gracilis muscle, or omental pedicle flaps, are commonly used to reduce complication rates associated with radiation therapy and extensive surgery. Anal adenocarcinoma and anal melanoma. Question: how is anal canal adenocarcinoma treated? Answer: anal canal adenocarcinoma is treated in the same way as rectal cancer, with neoadjuvant chemoradiotherapy followed by abdominoperineal resection for persistent disease. Question: what is the prognosis for anal canal adenocarcinoma compared to rectal adenocarcinoma or anal squamous cell carcinoma? Answer: anal canal adenocarcinoma has worse overall survival rates than rectal adenocarcinoma or anal squamous cell carcinoma. Question: what is the prognosis for anal melanoma? Answer: anal melanoma generally has a poor prognosis, with 5-year survival rates ranging from 14 to 31%. Question: what is the standard treatment for anal melanoma? Answer: surgery is the standard treatment, with local excision preferred over abdominoperineal resection if negative margins can be achieved. Question: how is immunotherapy impacting the treatment of anal melanoma? Answer: immunotherapy is altering treatment paradigms and shows promise in improving short-term overall survival for patients with anal melanoma. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.